We are going to move on at this time to our next speaker, who is Shelby Manjo. Uh, Shelby earned her doctorate in nursing practice from the University of Louisville in 2024. In October of the same year, she transitioned into the role of electrophysiology nurse practitioner with the pediatric and adult congenital electrophysiology team, where she continues to care for patients with complex rhythm conditions. Thank you so much for joining us, Shelby.
Hi, everyone. So my name is Shelby Monjo, and I'm going to be presenting antiarrhythmic medications that we commonly use in our adult congenital population. I have no disclosures. So objectives, I'll let you all quickly review these. And so a quick overview of arrhythmias within our adult congenital population. So arrhythmias are foremost in the challenges experienced in our adult congenital population and are the leading cause for morbidity and mortality within this population. And in fact, they're the number one cause for hospitalization in this population majority of the time. And they can lead to significant symptoms such as syncope, heart failure, thrombolytic events, and sudden cardiac death. And so there's a number of etiologies for these arrhythmias. A lot of times the underlying congenital heart disease sets these patients up for arrhythmias. The surgical operations, the cath-based interventions they've had lead to underlying scarring and residual suture lines, and then long-standing hemodynamic changes such as chamber dilation, reduced function, and residual lesions. And really, when we think about arrhythmias in this population, it's not a matter of if they're going to have arrhythmias, it's really about a matter of when they're going to have an arrhythmia. And so this slide is a really nice overview of common arrhythmias that we see within the adult population, starting with our atrial tachyarrhythmias. And like Dr. Iqbal nicely said, that these atrial arrhythmias, they're going to be our most common ones seen within the adult congenital population. Anywhere from our macro reentrant circuits, like the atrial flutter, to abnormal automaticity, such as focal atrial tach, ectopic atrial tach, and atrial fibrillation. And then moving on to the supraventricular tachycardia arrhythmia substrates, such as Wolff-Parkinson-White, our accessory pathway-mediated substrates in our AV nodal reentrant tachs. And lastly, our ventricular tachyarrhythmias. So these include anywhere from PVCs to macro reentrant circuits to abnormal automaticity. And so pre-therapy priorities. Before starting a patient on an antiarrhythmic medication, there's a couple of things that you really need to define first. So you need to identify and treat any sort of reversible causes, such as residual lesions. Do they have an electrolyte abnormality that is predisposing this patient to an arrhythmia? Any sort of abnormal thyroid function testing, and then obstructive sleep apnea is a common cause as well. And once you've decided that you need to start this patient on a medication therapy, you need to decide, is it rate control or rhythm control going to be of most benefit? And I'll go into that here in just a moment. And then you need to decide, oftentimes these arrhythmias, they're not amenable to procedures such as ablations because of how complex these patients are. And so is this patient going to be on chronic medication, or is this going to be a bridge to an ablation or a device placement? So getting into the differences between rate control and rhythm control. So the goal of rate control medications is to control the ventricular rate. So the goal of rate control is to control the ventricular rate by slowing conduction through the AV node. So this strategy does not terminate the abnormal heart rhythm. It just prevents the patient from having significant symptoms and prevents severe complications such as tachycardia-induced cardiomyopathy. And so common medications for rate control would be esmolol or diltiazem. Rhythm control, on the other hand, aims to terminate the arrhythmia and restore the rhythm to normal sinus. And so the choice between rate control versus rhythm control is highly individualized. It's based off a number of factors such as the arrhythmia substrate. Is it amenable to our rhythm control medications? What's the patient's clinical status, underlying heart disease, symptoms, and so forth. And so before moving into discussing the antiarrhythmic medications, we do kind of have to get into the fundamentals and basics of the cardiac cells. And this is where our antiarrhythmic medications are going to take action. So there's two action potentials specific to cardiac myocytes. And a cardiac action potential is an electrical impulse in the heart, and it is what generates the heartbeats and coordinates the contraction and relaxation of the heart muscle. So this first action potential that you see here is the fast response action potential. And this specifically occurs in non-nodal cardiac tissue. So our atrial myocytes and our ventricular myocytes that are responsible for muscle contraction. So in this picture, the action potential starts with phase 4. And during this phase, the heart is in diastole, or when the cardiac myocyte is in what we call a true resting membrane potential. And you can see the line above the number 4 is at about negative 90 millivolts. So what happens during this phase is potassium channels are open and potassium leaves the cell, which is what makes the inside of the cell negative. When the cell is stimulated, usually by a neighboring myocyte, you can see that the line goes to a more dotted line at about negative 70 millivolts, which triggers the next phase known as phase 0, also known as your rapid depolarization phase. During this, you'll see fast sodium channels open, which allows rapid reflux or rapid influx of sodium into the cell, and you see this sharp rise in voltage. Once it hits peak, it switches to phase 1, also known as early repolarization. Here, the sodium channels close, the potassium channels reopen, and calcium channels start to open. You then move into phase 2, which is your plateau phase, and this is where you have counterbalance of potassium leaving the cell and calcium entering the cell. And it's really important here is that calcium is what stimulates myocardial contraction. Lastly is phase 3, where calcium channels start to slowly close, potassium channels remain open, and potassium leaves the cell, returning it back to that resting membrane potential. The next action potential that you see here is the slow response action potential, and this specifically occurs in nodal tissue, such as your SA node, your AV node, and so forth. So these cells consist of modified myocytes that are actually lose their ability to contract and instead become capable of spontaneous and automatic action potential generation. So it is what initiates the electrical impulse. So again, starting with phase 4 in this picture of the slow response, in this phase, the membrane potential is pretty negative, usually around negative 60 millivolts. And there's this slow inward leak of sodium through what's called the funny sodium channels, which slowly increases that voltage until you can see that dotted line and it hits threshold. Once you hit threshold, you're now in phase 0, and this is where calcium channels open, and calcium flows inward, further depolarizing the cell. So note, with the fast response action potential, it was sodium that caused depolarization. With the slow response action potential, it's calcium that causes depolarization. At the peak of depolarization, it then switches to phase 3, also known as repolarization, where calcium channels close, potassium channels open, and allow potassium to leave the cell, returning the cell back to negative 60, similar to the fast action potential. So now moving on to the actual antiarrhythmic medications. There are a number of ways to classify these medications, but the Vaughan-Williams classification is a system that's commonly used amongst cardiologists and electrophysiologists in order to classify antiarrhythmic medications based off their mechanism of action. And so you can see here, there's 4 main classes. Class 1 starting with sodium channel blockers and so forth. And then there's a sometimes recognized class 5 or an other category where medications that don't quite fit in the 4 main categories get shoved into. So these would be medications such as adenosine, ivabradine, digoxin, and so forth. So starting with class 1 drugs, these are our sodium channel blockers. And so you can see here in the picture, the sodium channel blockers block that fast sodium channel responsible for rapid depolarization during phase 0 of the fast response action potential. So this medication is going to affect cardiac myocyte depolarization, has minimal effect on the nodal tissue. The interesting thing about class 1 drugs is they are further divided into class 1A, 1B, and 1C, depending on the degree of sodium channel blockade they provide. So in the picture, you can see the green line. That's our 1C sodium channel blockers. They have the most profound effect on that phase 0 slope. And then the red line is our class 1A. They have a moderate degree, and then 1B is going to have our weakest degree of sodium channel blockade. So starting with class 1A, these are our moderate degree of fast sodium channel blockade. So they are going to increase the QRS because they're widening that phase 0 slope, but they also have some effects on potassium channels, causing prolonged repolarization at the end there, that phase 3. So they can cause increased QT intervals. So these medications are going to include ones like procainamide and quinidine. So procainamide, this is a commonly used medication in EP. It is the #1 drug of choice for patients that have Wolff-Parkinson-White-related syndrome arrhythmias, especially with antidromic reentrant SVT or pre-excited AFib in patients that are stable. And this is a picture of what pre-excited AFib would look like. There are reports that you can use procainamide for chemical cardioversion of AFib and atrial flutter, and you can use procainamide for stable ventricular tachycardia, and this is in comparison to lidocaine and amiodarone. So consideration. So procainamide is proarrhythmic. It has a risk for torsades, and it is hepatically metabolized and renally excreted. So you need to monitor kidney function when starting this patient on procainamide. The active metabolite of procainamide is N-acetylcholine, which is NAPA, and you need to closely monitor procainamide and NAPA blood levels to prevent toxicity. Because of those class 3 effects, which are the potassium channel blockade, it can prolong that QTC and put the patient at risk for torsades. So usually when we start procainamide, we always do baseline and serial ECG monitoring. And then the last thing to know is with chronic use, you can have significant side effects such as GI side effects, agranulocytosis, hypotension, and drug-induced lupus. So moving on to class 1B, these are our weak sodium channel blockers. They really have minimal effect on the atrial tissue, and you're going to see they have the most effect on ventricular tissue. The interesting thing about class 1B is they decrease the action potential. So there's going to be no risk for torsades. So unlike class 1A, where it increases the QT, class 1B is going to decrease that QT interval. So this includes medications such as lidocaine and mexiletine. So the nice thing about lidocaine is it is highly effective in treating ventricular arrhythmias in the presence of myocardial ischemia. And the reason why is because normally myocardial cells, they control the amount of sodium entering a cell. This is called controlled depolarization. With ischemic myocardial cells, they lose that control. They allow rapid influx of sodium channels, which causes rapid depolarization, increased automaticity, and sets the patient up for ventricular arrhythmias. What lidocaine does is it blocks those sodium channels that the cell has now lost control of, which increases that electrical stimulation threshold. It prolongs depolarization, and it returns the patient's rhythm back to the sinus node. So it returns it back to sinus. So common indications for lidocaine, it's going to be acute treatment of ventricular arrhythmias. So ones like stable ventricular arrhythmias, especially post-MI, and is ACLS first-line agent along with amio for shock refractory ventricular fibrillation, pulseless ventricular tachycardia, and polymorphic VT. And lidocaine is especially effective in polymorphic VT secondary to prolonged QTC intervals. And it's not going to be a medication that you're going to use for chronic suppression of ventricular arrhythmias or for SVT substrates. So this is a nice example of when we would use lidocaine. So this patient had acquired prolonged QT intervals, and then you can sort of see 1/3 of the way into the page, they have R on T wave phenomenon, which sends this patient into polymorphic VT, reminiscent of torsades. This is actually an ACHD patient of ours, and we started her on IV lidocaine for 2 reasons. 1, it helped shorten that QTC interval back up, and 2, it helped to terminate this polymorphic VT arrhythmia. Okay, class 1C. So these are going to have the most profound degree of fast sodium channel blockade. So you can see excessive widening of your QRS interval, and you can see increases in your PR interval. And then note there's no effect on the refractory period, unlike your 1A drugs. So these include flecainide and propafenone. Indications. So there are a number of indications for flecainide: atrial arrhythmias, SVT substrates, and ventricular arrhythmias. Considerations with flecainide: it is renally excreted, so you need to monitor kidney function. It can be proarrhythmic and lead to malignant ventricular arrhythmias. So we do often start medication in the hospital and obtain baseline and serial ECGs and watch for any sort of proarrhythmic effects when starting flecainide. And then you do want to avoid the use of flecainide in patients with coronary artery disease, ventricular dysfunction, or patients that have AV block without a pacemaker. So this patient is on flecainide for SVT, and you can see here they have nice narrow QRS complexes. All the intervals are relatively normal for this patient's age. But unfortunately, this patient took 10 times the amount of flecainide for 3 days and developed flecainide toxicity. And so this is what their EKG looked like when they came in. And you can see there's profound widening of the QRS and severe prolongation of the QTC, and the PR interval is now 186. So this is what flecainide toxicity can look like and why we want to be very careful with this medication. Okay, so those were all of class 1. Now moving to class 2 drugs. These are going to be our beta adrenoreceptor antagonist medications, so our beta blockers. They have the most effect on our slow response action potentials. They're sympatholytics, so they're going to reduce the heart rate and they're going to increase the PR interval. They decrease contractility and decrease myocardial oxygen demand. They do have some fast response effects as well, and they're especially effective with catecholamine-sensitive arrhythmias. So common indications are going to be our reentrant arrhythmias that are nodal dependent, such as AVRT or AV nodal reentrant tacks. It's a really good medication for rate control properties in atrial tacks, atrial flutters, and atrial fibs. And we can often use this medication with ventricular arrhythmias, again, as specifically with catecholamine-sensitive ventricular arrhythmias. Considerations would be hypotension, bradycardia, and bronchospasm. And then this is a nice little chart of the differences between our non-selective and our selective beta blockers that we commonly use. And then esmolol is going to be our IV choice when it comes to beta blocker. All right, moving on to potassium channel blockers. These are our class 3. So you can see here potassium channel blockers block that potassium repolarization effect for phase 3 of the fast action potential. So it leads to increase in the action potential duration and increases the effective refractory period. So you are going to see increases in your QTC intervals with these medications. They are proarrhythmic, and most drugs in this class have additional EP properties. So the medications that we're going to talk about are amiodarone and sotalol. Amiodarone, this is a very widely used medication. It primarily exhibits class 3 properties. It has sodium channel blocking properties, calcium channel blocking properties, and then alpha and beta receptor as well. So there's a number of things that amiodarone specifically affects, and it has a wide use of indications. So refractory supraventricular arrhythmias, atrial arrhythmias, junctional ectopic tachycardias, and then ventricular arrhythmias especially. But the problem with amiodarone is the significant long-term side effect profile. So you have to be very selective in which patients you choose to put on amiodarone. So it can cause hepatic injury. It can cause thyroid dysfunction. So you have to closely monitor liver and thyroid function tests. It can cause severe lung disease, including pulmonary fibrosis, vision loss. It is proarrhythmic. It can cause photosensitivity, gray-blue skin discoloration, and many more. And so these are a couple of pictures of what amiodarone can do long-term. So long-term lung toxicity. And then on the right side of the screen is that example of blue-gray skin discoloration we can see with chronic use of amiodarone. Sotalol. So again, this primarily exhibits class 3 properties, but it also has some class 2 beta blocker properties as well. So it does have some effects in the SA and AB node. It's often indicated for the management of SVT and atrial arrhythmias, rhythm control for atrial fib, and then treatment of ventricular arrhythmias. Considerations. This is a long list of considerations when thinking about the use of sotalol. So it is renally excreted. You have to monitor creatinine clearance, and it's absolutely contraindicated if the patient has any sort of kidney dysfunction. You always want to obtain baseline and serial ECG monitoring when starting these patients on sotalol, and we will often admit these patients with continuous telemetry when starting sotalol because it can prolong the QT interval. And so it's very highly contraindicated in patients with acquired or congenital long QT syndromes because of how high risk it is for torsades. So bringing this picture back up, again, this is one of our ACHD patients, and she actually received 2 doses of sotalol. And just with that extra dose of sotalol, it caused such profound prolongation of her QTC intervals that it sent her into this polymorphic VT. So this is why you have to be extremely careful when starting sotalol. Moving on to class 4, so these are calcium channel blockers. These have slow response action potential effects. So they block that voltage sensitive calcium channels in phase 0 of that slow response, or phase 4 of that slow response. They also decrease the slope of phase 0 and slows cardiac conduction through the AV node, which increases your PR interval. These medications include diltiazem and verapamil. So with diltiazem, indication is primarily going to be used for ventricular rate control of your atrial arrhythmias. Considerations with diltiazem, the most common side effect is going to be hypotension, and you can see peripheral edema with these medications. It can cause varying degrees of AV block, so it is contraindicated in patients that have 2nd or 3rd degree AV block without a pacemaker, patients that have sick sinus syndrome, severe bradycardia, or severe congestive heart failure. And lastly, moving to the other drugs, I'm going to quickly touch on ivabradine because this has been a more commonly used drug in our adult congenital population. And so what ivabradine does is it selectively blocks the pacemaker funny sodium channels responsible for phase 4 depolarization of that slow response pathway. And so what it does is it slows spontaneous depolarization of the pacemaker cells, so it only affects the heart rate. There is no effect on myocardial contraction, relaxation, or ventricular depolarization. So indications, it is FDA approved for heart failure with reduced EF. It is used for inappropriate sinus tach, POTS, and then we have commonly been using this medication for atrial arrhythmias with focal automaticity, such as focal atrial tachs, ectopic atrial tachs, and then it's been a very effective drug for junctional ectopic tachs as well. So that was a lot of medications that I just reviewed. This is a nice little algorithm that a lot of EPs use. And if you can just remember double quarter pounder with lettuce, mayo, and tomato, and more fries, please, then you will always remember your sodium channel blocking medications. Your class 2 is going to be your LOLs. Your class 3 is going to be your SAD, sotalol, amiodarone, and then your class 4, diltiazem, and verapamil. This is a really nice little chart that kind of goes over the classes, the mechanism of action, which action potential is being effective, and common ECG findings that you can see with these medications if you all want to take a picture of this. And just as a wrap up, this is just showing you the 2 various action potentials and where these antiarrhythmics specifically affect those action potentials to prevent arrhythmias. Thank you.
Thank you so much, Shelby. I think that was a great review of antiarrhythmics and their mechanisms of action. And I can definitely tell you, any of you studying for, in medicine will see those things again. So I definitely agree with taking some snapshots of that talk.